Imagine that you are a doctor posted in emergency and suddenly a patient arrives squeezing his chest with his relatives yelling that he's having a heart attack. But you're smart. You know exactly when to start the MI management and how to differentiate between the subtypes. If not, let me tell you. So everything ties down to the degree of occlusion. If the patient is presenting with progressive chest pain, which is not present at rest and only present on exertion, you are probably dealing with chronic stable angina with an occlusion of about 70%. Coming on to the acute coronary syndromes, we have three subtypes: unstable angina and NSTEMI. So in both of these cases, the occlusion is 90%. What is the difference? The difference lies in the extent of myocardial damage. So in NSTEMI, the damage is more extensive, biomarkers appear in blood, and the ST segment is still not elevated because the ischemia still is subendocardial. Last but not the least, if you're dealing with STEMI, you will see ST elevations because the ischemia is now transmural and not just subendocardial. So why do we need to know this? Because if you're dealing with a case of acute coronary syndrome, immediate revascularization within 2 hours is imminent, along with the usual antiplatelet and anticoagulant therapy. Also, don't do thrombolysis in NSTEMI and unstable angina. So to summarize, pain is not present at rest in chronic stable angina. Immediate revascularization needs to be done in acute coronary syndromes, and don't do thrombolysis in NSTEMI or unstable angina.